Please help me welcome our wonderful speaker, Jennifer English. We are here for substance use among transplant candidates. Jenny English is a kidney and pancreas transplant licensed clinical social worker who has been at Banner University Medical Center in Tucson since 2021. Before moving back to her hometown in Tucson, she held this position at Cedars-Sinai Medical Center in Los Angeles, where she worked for over 10 years. She is a certified clinical transplant social worker and an ACMA accredited case manager social worker. Jenny psychosocially empowers patients and their social systems through the transplant continuum and serves as their advocate with the multidisciplinary transplant team. While in Los Angeles, she also was an adjunct professor at California State University Northridge in the Child and Adolescent Development Department. As the founder of Your Transplant Coach, LLC, a global virtual coaching and psychoeducational case management supportive service, Jenny helps Solid Oregon transplant patients and their caregivers better understand, navigate, and succeed in the transplant experience. Please help me welcome Jenny English.
It's so great to be here, and thank you for this opportunity, and thank you for joining me. This has really been a fabulous conference, and I'm curious, is almost everybody here a social worker? Yay, okay, we got our social work sisterhood here, awesome. So today I'm going to be covering substance use among transplant candidates, and we have a lot of things that we're gonna cover here and have some room for Q&A at the end. So I have no disclosures to make, and we have a few learning objectives here, including recognize and address personal biases towards patients with substance use disorders that may influence patient care, increase your practical knowledge of psychosocial and evidence-based assessment tools used for transplant candidates with substance use, develop a better understanding of why active substance use is generally an absolute contraindication for transplant, and identify resources for your clinical practice that can better help and inform you to treat patients with substance use disorders. So let's think of the context first. So there are 268 transplant centers here within the United States, and on average, 132 transplants were performed per day last year in 2024. 48,149 organ transplants were performed. And what's really exciting about this is this was the first time the United States performed this many transplants in 1 year. It was the first time that 48,000 transplants were surpassed. So this is really exciting when we think of future access to transplant and more people getting transplanted. However, as of last year, 104,480 people needed a transplant, and 58,482 people were actively waitlisted. So we see a disparity of more people needing a transplant than the people who were actually actively waitlisted. So in transplant, we're finding more ways to try to give access and increase those numbers of being able to get people transplanted. Now, thinking of substance use, more than 1 million people have died since 1999 from a drug overdose, and 68,239 drug overdose deaths occurred in the United States as of 2023. So I want to recognize that there is a cohort of these people who died who became deceased organ donors and did make transplant possible for our patients. 81.4% of these deaths involved at least one opioid, and so we certainly know this remains a huge crisis here in our country. 61.8% of these deaths involved at least one stimulant, and 69.5% of drug overdose deaths had at least one potential opportunity for intervention. And how that translates is oftentimes, if somebody presents, let's say, to an emergency room for other symptoms, maybe pain management, pancreatitis, and in the flurry of the emergency room visit, somebody wasn't able to be assessed or asked about what's going on, let's learn more, tell me, what's happening in your life. These opportunities can be missed to offer support, offer resources, and help give interventions. So let's look at first what a substance use disorder is. There are 4 key features when we're looking at somebody having a substance use disorder. The first is loss of control. So oftentimes there is a persistent desire to cut down or control use of the substance, yet those efforts are unsuccessful. We have severe psychosocial consequences. So to name a few, being unable to be stably housed, strained or dissolved relationships, unable to maintain a job or steady income, loss of function. This could be socially, recreationally, cognitive impairments in learning and memory, poor decision-making and impaired control of behavioral output. We can think of examples of like being drunk in public or inability to control anger. Then we have physiological dependence, which happens when there's a craving or strong desire or urge to use the substance, or when the use of the substance is recurrent in situations in which it's physically hazardous. So the big concept that we hope we are transitioning to and getting to as a society, and especially in healthcare, is the belief that a substance use disorder is not a moral failing. Rather, it's a chronic brain disorder because it involves changes to the brain circuit involved in reward, stress, and self-control. So our bodies and our brains, when somebody has a substance use disorder, remembers that when we utilize a substance, the pain decreases and pleasure increases when they turn and utilize their substance. So in times of trauma, stress, we can think of start of dialysis, recent death of a family member, these triggers that would make somebody want to respond of having some relief. Oftentimes, this is where they can return to use or continue their use. And the big thing here is changes persist after the substance use stops. So this is the big difference, what creates a difference between a substance use disorder versus other things that are misused, like gambling. Let's say somebody has dependency to sex. Very different than a substance use where there are still continued changes after that use stops. Now, we may be asked, my renal patient is not on fluid restrictions and has no liver problems. Are they able to drink alcohol and be considered for a transplant? Of course, it depends. So oftentimes, we really need to be looking at frequency of use. Do they have a past history of dependency? And how much are they drinking? If it's 1 to 2 servings, one night a week, on average, the team tends to be okay with this. But we always look at context and history and physical functioning and functioning within their role in the home and environment. So I think we're all pros at this point, is to pull out our phones and do a quick poll here. So the first question is, when working with a patient struggling with substance use, have you ever thought that they should have known better? Oh, I'm sorry, this is going to another slide. What are 3 words that would describe how you would feel, or how you feel when working with a patient who has a substance use disorder? We can throw out 1 or 2 words, that'll work too. Empathetic. Empathy. acceptance, compassion, education, true social workers in the house. Frustrated, yes. Resources, absolutely. Okay, yeah, these are really certainly compelling things that can come up when we're working with somebody with a substance use disorder. Okay, how about when working with a patient struggling with substance use, have you ever thought that they should have known better than to use their preferred substances? All right, absolutely. Well done, okay. So when we're really looking at, when we're working with somebody with a substance use disorder, there are so many factors that come into play often. And the social workers are bringing in that empathy and all those adjectives we just described. Yet it's not a common across the board, as we may know. Oftentimes we can have clinicians who do carry blame or cynicism and have this counter-transference. And us as humans, we all have our own experiences, have probably been impacted either personally or certainly within the work we do of seeing how substance use can impact somebody. And we bring all of that into the work and experiences we have with other people. And then we have our patient with a substance use disorder, and they are often facing fear of death, especially when we're talking about transplant, having mistrust towards the healthcare system that historically has not been the most sensitive, inclusive, and embracing. Shame as well, shameful of their use, not feeling comfortable and able to really disclose this and be open with this. And denial. Oftentimes people can be in denial of feeling like they have a problem or that it's impacting them. And with all of this builds stigma. And that stigma really creates an environment for people to not feel able to openly share, disclose, feel able and comfortable for asking for help. And so we have a long way to go here to be able to help bridge this gap and providing this inclusive and compassionate care within our healthcare systems. And oftentimes it starts with us needing to find ways to decrease that stigma. So when we look at the impacts of stigma in relation to the research that's been done with substance use patients, language matters. We can really weaponize with words, and we do see this often, unfortunately, in social media, or we can use our words to really help decrease stigma. And we do that by using person-centered language, which I think as social workers we really excel at. And that's where we recognize that people are first of all people. We don't say that somebody is an autistic person. We say somebody, a person with autism. Same thing, we don't say a substance abuser. We would say somebody with a substance use disorder. This language really does foster more of a connection and feeling more humanized. So here we always have, even though we really as social workers do shine in this area, when it comes to person-centered language, we are often provided opportunities to help educate fellow team members and people that we work with, or even friends and family, about how we can switch and change our language to be more inclusive, more humane, and more accepting. And it really does make a huge difference for the person on the receiving end by using that person-centered language. So there are two factors that the research shows that really influence stigma when it comes to substance use disorders: cause and controllability. So when people carry a belief that people have the willpower to quit or can get it together, really implies that someone can control their substance use, which again, knowing that this is a chronic brain condition disorder, is not the case. Also, stigma decreases if it's believed that a person did not cause their problem. Stigma can happen in the recovery phase as well, when someone is being prescribed medications to help them through abstinence or sobriety. And yet, oftentimes, there still can be this stigma and misbelief that we are trading one drug for another. Yet people stabilized on methadone, Suboxone, or other drugs to help maintain abstinence are not addicted. This medication is helping reduce cravings, withdraw, and restores balance to the brain. So to put it in a different context, do we say people being treated for diabetes are addicted to insulin? We don't, right? So as a culture and society, especially within healthcare, when we start having a paradigm shift and more of this, again, belief and understanding that this is something that is a medical condition that needs to be treated as such, we may see this differently. So, in being able to decrease stigma with person-centered language in relation to substance use, we can do these swap outs, and this is where we have opportunities sometimes to respectfully correct colleagues or, correct even people in our lives. I was talking to somebody the other day who was talking about her alcoholic husband, and I said, well, let's talk about maybe your husband uses alcohol instead of, calling him an alcoholic. We can say, instead of abuse, use. Instead of saying addict, user, crackhead, dope fiend, stoner, junkie, a person who uses drugs, or a person with a substance use disorder. Addiction, we can swap that out with substance use disorder. Clean or dirty talk screen, we can say in recovery or testing negative or testing positive. And switching out medication-assisted treatment for pharmacological therapy or pharmacotherapy. So now in the world of transplant, there can be some hard stops, just can't pass go when it comes to being able to approve somebody to be listed for a transplant. And there tend to be 4 main psychosocial hard stops. Now this does vary per transplant program, and this really should be clear in the policy for selection, listing, and evaluation criteria as well. But the 4 hard stops tend to be lack of post-transplant caregivers, adherence issues, so if somebody's chronically missing dialysis, not taking medications, leaving AMA from hospitals, they have to stabilize their lifestyle and being able to adhere to that plan so that after transplant, we know they can take medications and have the follow-up they need. Unstable or untreated mental health conditions can also be an immediate hard stop and absolute contraindication, as well as active substance use. And this is the one we're focusing on today. So this indicates when somebody presents to a transplant team, if they have concerning substance use within the last 6 months of working with a transplant team, this potentially could be a hard stop as well. So why is active substance use generally an absolute contraindication and can't move forward with getting a transplant? Well, without a period of sustaining sobriety, it's anticipated that a relapse would occur after transplant and result in the graft function of the transplant being compromised, which could lower long-term patient survival. So I'm going to share a little bit of a story. This was about 8 years ago. I had a patient who was a 71-year-old African-American male. And in Los Angeles, unfortunately, people can wait up to 12 years to be called in for their kidney transplant based upon blood type and other factors. So this gentleman had been waiting 8 years to get his call for his transplant. He made it. He came in, the transplant went well. Oh, and I'm sorry, I should backtrack. At his evaluation, there were no major red flags. Psychosocially, he seemed pretty low risk. He had very past remote substance use, like when he was 20 years old, smoked cannabis, had a little bit of cocaine in his early years. He was a beatnik poet. He was kind of an artistic type, but had reported a long period then, of no use. He had a supportive sister. He lived in kind of an artist compound within Los Angeles, so he had support within his home to also be there for him. Pretty independent, functioning guy, retired, stable income. Again, no major concerns. So we transplant him. He's actually off dialysis right away. 5-6 day hospitalization. We discharge him home. All of a sudden, the roommate refused for his sister, who was the primary caregiver, to come into the home. So that was very concerning. What's being hidden? Not sure what was going on there. But 3 days after he was discharged from his initial transplant hospitalization, he was readmitted for a ground level fall. And the report was that he was trying to get out of bed and had fallen and hit his head on a bedside stand and fell. So he came in and he developed a brain bleed from this hit and this fall. And the team decided, let's talk screen him and see if anything else maybe caused this immobility. And sure enough, he tested positive for cocaine. And looking back now, there probably was more recent use, more chronic use that none of us really were aware of, because our transplant center, Cedars, did not tox screen every single patient. It was only when clinically indicated. Sadly, it was an in and out process for him in the hospital from this brain bleed, in and out of rehab, and he ultimately didn't survive. And so we have things like this that can happen. And even though the kidney actually was working fairly well, with all of these other complications that really snowballed from this use of, a cocaine use episode at home, he unfortunately passed away. So, high-risk situations. Substance use may also be the cause of your patient's primary medical condition, so that has prompted the person to need the transplant in the first place. So continued or ongoing use would really decompensate the condition further and make the outcome of transplant futile. Now, there are some programs that do have limited sobriety protocols at some transplant centers. This is not across the board. It really comes down to centers that are open to taking more risks and have a lot of resources, usually in-house, for their patients. But this is most relevant for liver transplant programs. And as we know, some post-liver transplant recipients end up developing renal failure and end up on chronic dialysis, eventually needing a kidney transplant. So some of these transplant programs who have these limited sobriety protocols are modifying their substance use policies, which translates into people being able to be evaluated for transplant when they were drinking up until the day they were hospitalized and meeting a transplant team. And the reason this is being permitted and starting to happen on a case-by-case basis at transplant centers is to increase the access to transplant for people with alcohol-related liver disease. And in my experience, most of the people who this limited sobriety protocol applies to tend to be young patients, like in their 30s or 40s, whose health rapidly crashes, and they are now in the process of dying if they aren't given the liver transplant. However, a major qualifier for this exception to be granted to someone comes down to this needed to be their first episode of decompensating health, meaning they could not have had another history of, let's say, being in and out of the hospital, being told by doctors they will die if they don't stop their substance use, and then are readmitted at that point needing a transplant. So it really comes down to people in a category where this is the first time their health has ever majorly crashed and they hadn't been advised that they needed to stop their use in the past. Now, also, when we think of active substance use as being a contraindication to transplant, illicit drugs are not federally regulated. So it can contain various substances to make the drug it can take a lot of substances to make that drug that aren't known to the person using it, which can be another health risk factor. We know now, like fentanyl is being mixed into other substances that has fatal outcomes or very tragic outcomes. Other drugs that are out there that are mixed with many things. And when somebody's not knowing what they're ingesting, there can be really dire outcomes. And also, self-prescribing doses poses to be dangerous to one's health, and then it's hard for patients to track and difficult for providers to monitor. So when you're trying to assess somebody for how much are they using, let's say of cocaine, and they say, I don't really know, that's risky. And as we know, there are social impairments as a result of substance use, and that can become financial consequences, job loss, relationship strains, and legal issues, which all can become a big hardship when we're looking at transplanting somebody and really hoping that that goes well and they have a good outcome. So many programs follow a 6-month time frame of sobriety in order to be listed for a transplant or considered for a transplant. The kidney transplant programs I've worked for do require this 6-month time frame if there has been concerning active substance use disorder concerns. 6 months in general allows for somebody to be referred, accepted into a treatment program, work that program, and be able to have a period of time of sobriety. Now, oftentimes, depending on the type of program, they will do tox screens, and this is how transplant teams basically prove that somebody is abstinent. And so when we decline people for transplant and ask for them to go work on this 6-month time frame of stabilizing their use, these programs also can provide us proof of treatment, and from that point, we're willing to reconsider them for a transplant evaluation. And then we're monitoring those patients more closely, and social workers will do more check-ins, whether it's quarterly. We're certainly seeing our patients yearly, but we have more eyes on these patients. And it's always a team approach. We are never alone when it comes to helping our patients on a transplant team. We oftentimes are reliant heavily on psych. Some teams have a psychologist, some have a psychiatrist, some are fortunate to have addiction medicine. Social work, we're focusing on that social impairment piece. Is their substance use going to cause them to have strained relationships from the caregivers who are going to abandon them? Are they going to be able to make it to appointments and engage in their health care? Psych really looks also at that impaired control and risky use, and you'll see there's certainly that overlap between social work and what psych tag teams on. And then our medicine and surgery is looking at that dependence and end-stage disease piece. So it's a CMS requirement for all patients to have a thorough psychosocial evaluation in order to be listed and approved for a transplant. And the goal of that comprehensive psychosocial assessment is to identify risk factors, protective factors, and social determinants of health prior to transplant, so interventions and recommendations can be implemented based on that evaluation. And the goal here is anything that needs to be stabilized or worked on should be done prior to somebody getting that transplant, because once somebody is on all these new medications, recovering from surgery, having just a full-time job already, focusing on their transplant aftercare, it is hard to all of a sudden get into Section 8 housing or be able to stabilize your insurance situation, things of that nature. So this assessment really helps us gauge what we can advise and help patients on in preparation for transplant. So the common psychosocial assessments for transplant that are used are the SIPAT and the Society of Transplant Social Worker Psychosocial Risk Profile Tool. So quickly, the SIPAT was created by a psychiatrist named Dr. Jose Maldonado at Stanford, and it stands for the Stanford Integrative Psychosocial Assessment for Transplantation. When it's completed in its true form, it can take up to 2 hours to complete. And then what do we all love as social workers? Documentation? No, joking, right? It can take actually 2 hours to even document this full eval as well. So can you imagine 4 hours of meeting with somebody and then doing the documentation? That can be a really time investive process. And for high volume transplant centers, this can be a little bit of a challenge. Also, the SIPAT, at the end, you get a score for the risk, the psychosocial risk for your patient. And I could see the same person as you, and we could have totally different numbers for their psychosocial risk. So it kind of begs the question, is this really kind of an objective assessment, or as objective as it could be in the end? One of the main concerns some social workers have regarding the SIPAT is that it does not heavily factor in people's protective factors. And it takes more of a pathologizing psychiatric lens view, or that medical model approach of evaluating a patient. Yet, SIPAT is the most frequently used transplant evaluation tool, as it has been studied, has been reviewed, and widely accepted as a psychometric instrument designed to assess a patient's psychosocial risk for transplant. However, us social workers, we really look through that social work lens, not a psychiatric lens. We take that strength-based approach, looking at a person within the environment, valuing self-determination, and the STSW psychosocial risk profiling tool is more inclusive of those elements that really align with our social work values. So the centers I have worked for, we utilize the STSW psychosocial risk assessment tool. It has all of the same areas that we assess as the SIPAT. And if anybody, just for learning purposes, would like to see the full version of this, you can email me. I'm happy to share this so you can see. What are those areas that we're assessing? We're looking at medical history, psychosocial history, current living arrangements, education, employment, insurance, post-transplant caregiver plan, functional status, adherence history, advanced directive and advanced care planning, substance use history, legal history, coping, psychiatric history, understanding of illness and transplant process. This is a lot for us to try to get a snapshot and picture into somebody's life and pick out some of the risks and things that might need to be stabilized before they could succeed with a transplant. I would say on average, unless it's a really complex patient, these evaluations tend to take me about an hour. So this is a little snapshot of what part of this STSW tool that we use looks like. We've kind of modified it to our own style. But when we're asking about substance use history, we want to know about the family history. We want to know if the person has experienced any legal consequences related to their substance use. And then we'll ask, basically line by line, about the different substances. And we want to know about when was their first use, their last use, what type are they using, how frequently are they utilizing that substance, how much, if they can quantify that, how they stopped and why they stopped, what was their motivation. And through that, if there are any triggers that make us want to get a more temperature read and a little bit of a better situation to grasp the severity of this, we then would want to complete either the DAST, the Audit C, CAGE, or the CAUDIT R. The DAST is the drug abuse screening test. And again, I have a little bone to pick with them. We should change that to drug use screening test, probably, not abuse. But the DAST assesses the last 12 months of somebody's use. It's a 10-question screening tool, and it's something that you can easily do in the setting of your evaluation. And depending on what electronic health record system you use in your centers, whether it's Epic or PowerChart. Sometimes there are ways for these assessment tools to be embedded in your documentation, which is kind of nice. There's also the CAGE, which is a 4-questionnaire and a screener for alcohol use disorder. The Audit C is the Alcohol Use Disorders Identification Test, concise. And then there's the CUDIT R, which is the Cannabis Use Disorder Identification Test, and it's an 8-question screener. So that allows us to really get a sense of whether, is there a concern and do we need to refer this patient to psych? Because as you saw, we're assessing so many areas of somebody's life. When we need a more in-depth take and have more of a full screen done on some of these risk factors when it comes to substance use, we're gonna want that patient to be fully evaluated by the transplant psychologist or psychiatrist. We then also, of course, are looking at mental health and psychiatric history. And in asking questions about present and past mental health conditions, psychotropic medications people may be on, been any history of psychiatric hospitalizations, or let's say frequent emergency room visits for panic attacks, any past current homicidal or suicidal ideations, trauma history as well. Any red flags or concerns from that, we go and do another brief screeners, whether it's the patient health questionnaire to screen for depression, the Columbia Suicide Severity Rating Scale, or that General Anxiety Disorder 7, the GAD-7, looking at anxiety. So this is an example of what the final risk assessment will look like from STSW's risk assessment. And again, we should have that substance use. I should talk to STSW about that. Anybody that falls into the low risk category is gonna continue to go on and be fully evaluated for transplant. Moderate risk would be somebody that we want to have a little bit more case management check-ins with and monitor. High risk is when we get very concerned. We're oftentimes either from our evaluation explaining that they do need to receive treatment and work on maintaining their sobriety, or also connecting them to transplant psych and have more of an assessment so that we can give the patient then a really comprehensive full picture of what's needed for them to stabilize and come back. So a very hot topic, of course, these days is cannabis use, and especially in the setting of getting a transplant. So it's important to really look at the big picture first regarding cannabis. So under the DEA's Controlled Substance Act, cannabis is placed as a Schedule I substance. So under this act, substances are placed in either a 1 to 5 schedules based on the substance's medical use, potential for dependence and misuse, along with safety considerations. So cannabis is in the Schedule I category, along with heroin, LSD, ecstasy, and psilocybin mushrooms. So a huge challenge with cannabis being a Schedule I substance is that it doesn't allow it to be researched, and there's a lot of red tape to being able to get approval to research a Schedule I substance. And unfortunately, there's no federal funding to research Schedule I substances in general. So we're left with very little research and evidence to go on when we're looking at drawing conclusions about cannabis, medical benefits, and especially the impacts it can have on transplant recipients. So we have very little research to go off of. So ultimately, it's organ and program specific as to whether a person receiving a transplant or being evaluated or listed for a transplant is able to utilize cannabis. Most programs, though, in states that have legalized cannabis recreationally and medicinally take a more liberal approach to permitting its use in the setting of transplant. So, for example, in California, it was pretty widely accepted for kidney transplant recipients that they could utilize cannabis. Insurance providers, though, generally defer to the transplant center's program requirements. So let's say a program does tox screen all patients. The insurance is not going to provide authorization without seeing a negative tox screen. So some insurance providers, though, may have their own requirements, and that's something that the transplant teams have to navigate. One general consensus, though, is that people have to be using edible cannabis, not smoking or vaporizing it, due to the risk of aspergillosis. So when somebody utilizes edible cannabis, it gets metabolized into the bloodstream, whereas when somebody smokes or vaporizes, you're using your throat, your esophagus, your lungs, and can develop a fungal infection in the lungs, which places a higher medical risk. So the general ask of our patients is to switch from smoking and vaporizing to edible use. However, kind of a problem with this is that there's no diagnostic test to determine the type of cannabis use. So I could easily have a patient tell me, sure, I've transitioned to cannabis edibles. I don't smoke any joints, nothing like that, but we have no proof. So, is it really a fair ask to be, requiring this when there's really no way to litmus test to really prove them being on edibles? So just a thought. And whether somebody's allowed to utilize cannabis really does depend on their past history, whether we're going to allow it. So if somebody does have past concerning use, let's say with other substances, and now is just utilizing cannabis, that's discussed with the team, and we take a look at whether we will continue to allow that use. And then it's important that patients do get education about the potential risk for cannabis to impact the immunosuppression drug levels after transplant. So basically, the minimal research that has been out there does indicate that tacrolimus, which is one of the anti-rejection drugs after transplant, those levels can vary with THC in the system. So basically, a patient needs to be aware that you're at a higher risk of rejecting your organ when you continue cannabis use. So let's talk about challenges we see in the pre-transplant phase. Toxicology tests often contradict patient report. I can't tell you how many times I've sat with a patient who says, no, I've never used cocaine, I've never used meth, I don't smoke marijuana. We do a tox screen, boom, positive for cocaine, positive for meth. This is hard then, right? We're here having to say, well, now you need to do X, Y, Z to be able to move forward, but the patient really is in that denial phase. PEth tests is what we do to look at alcohol in the system, and it actually can detect alcohol for the past 30 days. So if somebody presents saying, I have not drank recently, you run the PEth test and those levels are moderate or high, they've been drinking. And per transplant program policy, mandating completion of a relapse prevention program or substance use treatment program is difficult. It's like patients feel like they're being court mandated to go to treatment. And if somebody really isn't ready to change and want to work on this, that's a challenge, right? We're requiring you to do this for 6 months, come back, yet, that can be a real hard thing to navigate sometimes. And also determining what treatment program that we're mandating them to do. Recently, we put a new policy in place at Banner Tucson to make this more standardized. So in selection, we weren't saying, oh, this person tested positive for meth, a year for you, or cocaine, 6 months for you. We really wanted to take that randomness away and make that more equitable and standardized. So we recently instituted a new policy that makes it clear what programs people also need to do. It can be also challenging early in transplant phase of tracking completion of the program in random tox screens. and determining when somebody can be re-referred back, or when they're listed with our program, switched from status 7 to status 1 listed status. So this is more relevant for liver transplant, but what if the patient is incapacitated and can't answer transplant evaluation questions? Highly difficult. We're going off of chart reviews. What info can we find in the chart? Past tox screens? Is there any documentation in there where the patient may have disclosed to a doctor that they did have use? We're then interviewing family and the surrogate decision makers and making a determination at that point, which can come with its own risks too, as far as how valid is that feedback. Another challenge, of course, is this mistrust, being watched and feel like the patients are being more case managed more closely than other patients. Yet at the same time, especially for us social workers, it really allows us to build a stronger relationship and that rapport with our patients, since we're going to be having more frequent contact, hopefully trying to decrease some of that mistrust. And access to programs in the community, along with insurance coverage for services, can be really tough. You know, depends on where you live and or where the patient lives and what their insurance options are, being able to enter into community services. And then really wanting to take a harm reduction approach, as this is really the most effective when it comes to substance use disorders and treating those. Yet on the transplant side, having this zero tolerance, so that becomes tricky. And then another big tricky aspect can be, does the patient's caregiver or their support system know about their use? We are heavily reliant on our caregivers for our patients because they are really the glue that holds our patients together. And if they are unaware of the use, this can be really hard. Like that case I mentioned earlier, his sister had no idea, and we never disclosed to her that this fall happened likely from his cocaine use. And some programs do have what's called like a terminal closure policy. So basically means there are too many risks for the program to want to take in being able to approve or allow you into the program. So some patients, you know, the most kind of dire outcome is not being able to come back to the program and being sent out to get a second opinion. Thinking of post-transplant, patient mortality rate and survival. If the patient dies prior to their 1-year post-transplant anniversary, the transplant programs take a really big hit. And of course, the worst outcome is being put on pause or being shut down, and then other people aren't being able to get transplanted. Increased utility of healthcare services. This is big, you know, coming into the emergency room more frequently, having more outpatient clinic visits, just utility on the healthcare system can be challenging. And then if the transplant complications occur, really again, that risk of returning to use as a coping strategy or having decompensated mental health is real. And this can translate into missing appointments, lab draws, not taking medications, and really detaching from the transplant team. And this is state specific, but at least in Tucson, Arizona, the police department and law enforcement will not do wellness checks. So if we have not had any contact from our patient, we're calling emergency contacts. We have no idea what has happened to them. The one resource we have to tap into to go door knock and see what's happening at home isn't there. So, you know, this is a big challenge after transplant. We had a case not long ago where actually our physicians ended up going to the patient's house, which I, you know, kind of had some feelings about, yet what can you do? And when you're really trying to be there to support this patient and see what's happening, you know, this can be a tricky thing. Caregiver burnout is real. You know, this can really be a huge challenge after transplant as well. So once the patient does get transplanted, what do we do now, especially supporting our patients who have a history of substance use disorders? The key really is not missing opportunities to check in, ask about how they're doing, check in about their substance use, mental health, and offer help and support. That use of self and showing up, that relationship building really can make a huge difference when it comes to being open to disclose what's going on and being ready to get that help that they need. And then the special sauce for social work oftentimes is motivational interviewing. Being able to use our MI skills to help elicit change is big. So those open-ended questions, those affirmations, reflections, summaries is huge. Lean into that relationship that we've hopefully built at this point with our patient and really use that rapport as that ability to help show them that we care about their well-being and we want them to succeed. And maximize whatever internal resources we can tap into. So if we do have psychiatry, addiction medicine, if somebody had established with mental health providers in the community or had still been engaged with their substance use treatment program, really helping elicit all of that help. And going back to using our patient-centered language, that really is golden, and using our evidence-based tools and practices where we don't let those biases come in. Recommend continued engagement in the substance use treatment programs and continued mental health care, and really mobilizing that social support our patients have, because that is really key. So some resources that I hope can be helpful to you. One of my favorite locators for substance use treatment programs and finding mental health care when you struggle through other avenues is going to SAMHSA's website. They have a treatment locator where you can go in, you can type in your patient's zip code or city that they're in or town, and it will pull up within a certain mile radius treatment programs. So this has been really key for when I work with patients out of state and I have no idea what might be available there, or for patients who are in more remote areas that may not have access to coming to where you are as the provider. Smart recovery is a really popular treatment model in substance use treatments. Free, there's a lot of virtual groups. The best $35 you could ever spend is on this book called The Clinician's Guide to Substance Use Disorders, Practical Tools for Assessment, Treatment, and Recovery. It was written by a social worker and just has so many incredible things that you can use in your practice. And then of course the motivational interviewing book. And then this is a really fabulous resource for families. A guide for families beyond addiction, how science and kindness help people change. I don't know if anybody watched that A&E show back in the day, Intervention, that was like this traumatic, experience and kind of takeover where the confrontation of the person who was struggling with substance use and then rushing them off to rehab. This is not the approach. So this really is a fabulous resource to give to families when they are really wanting to help their loved ones. And then there's just so many great resources and information on the National Institute on Alcohol Abuse and Alcoholism's website, the American Society of Addiction Medicine. They have CEU opportunities there. The American Thoracic Society, they have great patient resources, and I have two favorites that I hand out a lot to patients. It's the aspergillosis one and marijuana. So when we're educating patients about converting from smoking or vaporizing cannabis to edible use, I print these and I will give that to my patient. So that really helps show just the science behind why we're asking for them to change their use. And there's a free CEU opportunity on Stanford's online website called Unconscious Bias in Medicine. Gives you a free CEU if you're interested in that. And then this last website has really a comprehensive PDFs for all of these assessments related to substance use disorders. And it has them in Spanish and English form. So instead of Googling and deep diving, having to find those randomly, that's really a nice one-stop shop. So thank you for your time, and I'd love to open this up to any questions or comments.
And I have two that were put in the app. Can you explain the status levels?
I'm sorry?
One of the questions in the app is, can you explain the status levels?
Status level, sure. So once somebody is approved and ready to be put on the United Network of Organ Sharing, the UNOS transplant list, they can be either listed status 1 or status 7. Status 1 means they are cleared from all specialties and really can be active and ready to get a transplant at any given time. So once somebody's status 1, it's go time. They could get that call anytime. Status 7 means they are on the transplant list, but so they'll continue to get their wait time and go up on that list, but they're not active for transplant offers. So it generally means there's something pending that needs to happen for them to go from status 7 to status 1. Oftentimes it's medical. They may need to complete a left heart cath, or sometimes it's insurance. Sometimes insurance lapses and we can't call them in for a transplant until insurance gets situated. So those are the two common statuses.
Thank you. Another question on the app is, how does working with patients in other states work with your social work license?
Great question. So we have all of our patients come physically to our transplant center, and as of now, we are doing all of those evaluations in person. So I'm licensed in California and Arizona, so I do tend to take most of the California residents, but when we have checked with our licensing board, they have essentially said it's okay because we're under the view of the patient is physically in Arizona when we're evaluating them and treating them, and we're still collaborating with their primary care providers in other states. That's a great question because we certainly do need to protect ourselves and protect our licenses too.
Great. Any other questions?
I have a question.
Sure.
I work in a dialysis unit and we refer obviously a lot of patients for transplant, but some of the roadblocks is that like the patients who use marijuana like recreationally, we've had some issues with some transplant centers that like they can't trust that like maybe the patient is only using edibles, or they can't trust that the patient's only using maybe like once every so often, and they've gotten rejected for a transplant, but then we'll send to maybe like another center and the patient will get transplanted and do very well. Do you have any advice on how to advocate for maybe some of these more strict sites on how to advocate for the patient?
That's a great question. My first question for the transplant center would be, can I see your policy on marijuana use and what is permitted? And then if it's not in policy, then directly speaking with the transplant social worker and then advocating for your patient, saying, this is what I've seen. Compliance, they're doing well, you know, they're high functioning, their support system is great. This isn't impairing their day-to-day life for treatment, if that's the case. Yeah. You know, your voice, we rely so heavily on our dialysis social workers because you see these patients and have more contact than we do on our side. So, you know, I would push back and double check if they even have a policy in place, because if they don't, you know, then that's that bias piece coming in, and how do you really give access to people when, you know, when they can do well still. So I hope that was helpful.
Yeah, that was helpful.
Yeah.
Thank you.
Okay, sure.
Any other questions? Thank you. That was wonderful.
Thank you. Appreciate it.